So, good afternoon. So, today I'll be talking, alright, kakatapos lang na. So, if anyone needs to go out from some, if you want to drink, get some coffee, etc., it's okay. I'll just continue kasi medyo mahaba ng konti, although I hope to finish it early, okay? And then, so if you want to go out, get some drinks, it's okay. So my lecture is about diseases of the aorta and the vascular system. So objective is to familiarize you with some of the diseases that it may involve your aorta and the vascular system, including the arteries and the veins, no? So if you're familiar with the next slide, di familiar? Ninenong ko lang kay Dr. Gomez yan. Okay, so just an idea on what happens and why diseases of aorta, the vascular system, do happen is because of the intrinsic characteristics of your vascular system. So we all know that for lumen diameter, the veins followed by the arteries and the capillary with the lowest lumen diameter. However, arteries are thicker compared to the veins because of the more muscles in the intima region, no? And then rather the veins, and obviously capillaries have no muscles, no? Blood distribution, veins have more because of their large capacitance, okay? Compared to their arteries and your capillaries. The total cross-sectional diameter is larger for the capillaries, followed by veins, last by the arteries. However, velocity is faster with the arteries because of a thicker muscle they push. So there is increased shear stress, etc. Pressure again is higher in the arteries with veins having the lowest pressure. So imagine a wheel, mabilis pagbaba, pero mabagal pagtaas. Because of the heart pumping going down, okay, then going to the capillaries, going back, it's due to the valves that keeps pushing the blood up, going back to the heart. Pressure again is higher on the arteries because of the pressure brought about by pumping action of the heart, followed by the capillaries, and the least pressure is your veins. Resistance also follows the same route with the aorta, having the most resistance, followed by your capillaries and your veins. So these are just the characteristics to give you an idea that the bigger does not necessarily mean more resistance, no? Sometimes it's secondary to the intrinsic histology of the vessel, whether it has more muscles, less muscles, no muscle at all, the size of the lumen, and whatever attributes that may contribute to the condition of the patient. So we'll start first with the aorta. So aorta has a very thick intima media, no? So it's a strong muscular layer, okay, followed by your inner one, it's the intima, and your adventitia. So you have your ascending aorta, your aortic arc, and descending aorta. So ascending aorta, the mean aortic diameter is about 3 centimeters. Aortic arc is around 2.5 to 3, it depends, no? Descending thoracic, going down until your thoracolumbar aorta, the lower the diameter. Aortic length would definitely be a little bit different from the descending and the thoracoabdominal because of the differences in height. However, the risk for developing thoracic abdominal aortic aneurysm is higher for the ascending aorta. Because why? This is where the initial pump of the heart comes out. So more pressure is here, then pressure goes down as it lowers. No? So risk for developing aneurysm is highest in this area because of the shear force associated with the pumping action of the heart. So we start first with the different diseases of the aorta. You can have your congenital anomalies, aortic aneurysm, acute aortic syndromes, aortic occlusions, and inflammation, aortitis. Right? So aortic aneurysm is defined as a pathologic dilatation, paglaki or pagbilog of a segment of a blood vessel. A true aneurysm involves the intima, media, adventitia. Okay, so all three layers are affected, while pseudoaneurysm would involve sometimes the intima and the medial aspect lang. So bubukol lang, but not necessarily involving the whole layers. So when you have true aneurysm, the whole wall weakens, while a partial pseudoaneurysm is that only a slight part of the wall bulges because of the pressure. Okay, so not necessarily the whole the whole vessel is involved. So it can be defined as a fusiform, which affects the entire circumference of a segment of vessel, which is diffusely dilated artery. So yan. Or you can have a saccular, which is only a portion or an outpouching of a vessel wall. So this can be a pseudoaneurysm wherein one part enters the vessel wall, causing an outpouching. So we sometimes call it the saccular. Fusiform are the more common ones. The more, what do you call this one? The more involved, the whole layer is involved. Okay? So various etiology can be associated with development of aneurysm. So medial degeneration or the degeneration of your intima media to something less of a muscular to more of a myxoid condition is usually seen among patients with genetic developmental problems. Alright? So you can have your Marfan syndrome, the Wittage syndrome, Ehlers-Danlos type 4, Turner syndrome, familiar, bicuspid. They have mutational conditions like in fibrillin, your tumor growth factor, tissue growth factors. They have problems, mutations in the development. There are more elastic fibers, and these mutations allows for the vascular, for the aorta to become more prone to degeneration because of a mutation in the components. Other conditions that may predispose you to aneurysms are your age, the older you are, history of smoking. So if you're male and a smoker, by a certain age, you need to be evaluated regularly for aneurysm. Hypercholesterolemia because of atherosclerosis. Because of the hardening of the artery, more shear forces act on it, causing the development of aneurysm. Hypertension and atherosclerosis, which is also a direct action of your hypercholesterolemia. Conditions that may predispose you also are the conditions like autoimmune diseases, which directly attack the vascular system. Conditions like your vasculitis, wherein your lymphocytes attack directly and damage your vascular system, and other rheumatic diseases. Infection like syphilis, tuberculosis, and fungal infections also attack due to either rapid spread, your syphilitic aortitis, which causes a degeneration, or mycotic, which is direct invasion. Okay? So, aneurysm can be classified as abdominal aortic aneurysm, thoracic aortic aneurysm, and thoracoabdominal aortic aneurysm. So, it depends on where it is, okay? And you will define it by location. So, for thoracic aortic aneurysm, it's, again, the most common is medial degeneration. It usually acts on the ascending aorta. Now, for atherosclerosis, it is usually affected by the descent, usually seen among patients, is seen in the descending thoracic aorta by incidence. Okay? So if you already have it, the growth is about 0.1 to 0.2 centimeters yearly, about 1 to 2 millimeters yearly. So it's a progressive thing. Okay? So in spite of the fact that you already have aneurysm, you should need to be maintained, controlled, and re-evaluated because growth or worsening of that aneurysm occurs yearly. So for people with thoracic aortic aneurysm, how much? What is the prognosis? Okay, if your aneurysm is less than 4 centimeters, your risk for rupture is only about 2 to 3 times a year, and that's the reason for the regular diagnostic examination. However, if it's more than 6 centimeters a year, the risk goes up by 7%. So tumataas siya. Habang tumatanda ka, lumalaki, your risk for rupture increases. So 6 is the magic number. So if you have 6 and above, your risk is higher. Huh? Now, what are the signs and symptoms? A lot of people, you might have heard of your cousin, neighbor, etc., suddenly die and they tell you it's aneurysm. Okay? So most of them may be symptomatic. Others will have signs and symptoms based on compression of the underlying structures. They may have chest pain. They may have paraplegia. All right. Initially, they will take it might be stroke, but on further examination, it's just aneurysm impinging on it. They could have other signs and symptoms that may be associated not with the aneurysm, but with the organ being compressed. So it may be a lot of things. No? So diagnostic could be a little. May be seen by chest X-ray. Chest X-ray, you can have it done. You do it yearly. Even you, when you enter here, hopefully get an X-ray. So you will see a widening of the hilar mediastinum. So it's already a first clue. So lumalaki yung aortic arch mo. Echocardiography, specifically your esophageal thoracic echocardiographic echo, will see the size and presence of thrombus. So very important yung EET. Contrast CT scan and MRI, they will tell you the size, the location, specific location, and the presence of any further aneurysms along the way. So it gives a full view on what the problem is, how extensive is the problem, and what are the things that we could do. Invasive aortography is usually done if we want to see the whole aorta, the whole vascular system, no? The whole aortic branches. This is rarely done because it can be seen already in your contrast CT or contrast MRI. So this one are the two non-invasive, and this is the most, it's the best. Okay? This is, if you want to determine the size, chest X-ray is a screening, but it's not usually requested only for a different indication. Annual PE, chest X-ray, lumaki. Oh, sandali, CT scan. Okay, echo, oops, I see something. We do an EET, and then what they see is a widening, an aneurysm. Sometimes they will still again go to this one. All right, if you have a high suspicion, go for CT and MRI. More expensive, but in the long run, it's the best modality that you use. So, how do we manage? So, what causes aneurysm? Diba? Increase what? Pressure, shear force, destruction, degeneration, lumanan. So, how do we reduce the size from getting bigger? Reduce the pressure. All right. So, how? One, by reducing the hypertension or reduction of the blood pressure. Two, slow down the heart. Kasi your heart, if it's beating normally at 90, and this is your vascular system, masisira, right? But if you lower down your heart rate, lower down the blood pressure, okay? So the tendency for the shear force associated with the increased cardiac output is actually reduced by taking this medication. Okay? Now, if things get worse, you could do replacement of your ascending aorta through the use of your bicuspid aorta and the use of your aortic valve replacement, because sometimes there could be aortic valve conditions. Repair is through the use of your prosthetic graft, and these are for patients with symptomatic ascending aneurysm. They replace it with your bicuspid aortic valves and are indicated only, again, the number is 6 or more than 5.5 centimeters or a growth rate of more than 0.5 centimeters a year. So last year it was 4.5, today is 5. All right, that's already a good marker for much more increased surveillance. And if the next year is 5.5, it's already a good indicator that we need to have this repaired. Now, for those with degenerative descending thoracic aorta of more than 6 millimeters, you could have an endovascular repair. So what they do is they put a stent, all right, inside, and they replace that area that is that has that aneurysm. Okay, for those with 4.55 or those with an increased diameter of 1 centimeter a year. So this one is already your indication for treatment. Now, from thoracic, we go to abdominal. For abdominal aneurysm, again, males, elderly, history of smoking, and